thank to the committee for the opportunity. I will be talking about the provisional stenting, which is the result of the consensus of the European Bifurcation Council for last year. And the first paper was published last year. Actually, the technique is quite similar in this guide, especially the challenges during the provisional stenting are mentioned, and some solutions are recommended. And here a new terminology has been used. Step-by-step provisional stenting is the new terminology. And as you know, in many bifurcation techniques, this is a strategy that we use. Here, the stepwise layered logic is depending on the course of the lesion, the strategy may change. And this terminology was seen to be better. And starting with a single stent and terminating with a double stent, completion with a double stent is the possibility. Therefore, stepwise technique terminology was used. And main across side forced standard provisional stenting or across distal main first is inverted provisional stenting. These are the two main categories. When we say the main vessel or across side branch, as we all see, the stenting is done from the proximal main vessel to the side branch. And a different side branch terminology will also be mentioned. In inverted provisional, from the main level to the side branch, the stenting is done. Here, the main element, the distal part of it is called the assigned side branch. As we see in the paper. We all see that in real bifurcation lesions, this may be 101, 111, or 011, single or double stenting may be in question. And to answer this question, there are some studies, but there's a confusion about this. The single stent strategy seems to be more efficient and safe in the long-term randomized controlled strategies, especially in the 1 year's follow-up. The single stent and strategy seems to be less mortal compared to the double stent one. And when we look at the steps in the provisional stenting, we take a stent compliant with the diameter of the distal main vessel, and we also place the stent for the main vessel for the first time to cover the side branch ostium, and two-step part is recommended if there is one-to-one compliant balloon. In the long proximal stents, at two-stage part is recommended, and also a rewiring is recommended from the distal of the side branch, and a final repot is the completion step. And then when there is any unwanted angiographic result or dissection, then T-tap or kill-up is also recommended after the provisional stenting. In the real complex bifurcation lesions, in definition 2 study, we saw that in real lesions, especially if the side branch lesion is more than 10 millimeters, a single stent strategy provides better results. And in real bifurcation lesions, if the side branch or if the assigned side branch is less than 10 millimeters, single stent strategy may be adopted. In provisional stenting, there are steps called ABC. In stage A, main vessel and side branch are wired. And in provisional stenting, a jailing wire technique is recommended. And after this, if the flow is occurred in the side branch, then a microcatheter or balloon can be used to ensure the flow. And in the multi-center tulip study in France, without a jailed wire, the angiographic procedural success rate is low and reintervention is more. And in another study, in the provisional stenting with jailed wire, less occlusion is seen in the side branch. And about the wiring of the side branch, there are a few recommendations, especially when the tortuosus and open side branches. If pullback is done with a wiring, workhorse tail or hydrophilic polymer covered wire can be used, and for different angles can be shaped on the end of the wire. A single angle and short end 2 to 3 millimeters, or a single angle and long end can be used, or a wider angle can be used, or 2 angles can be used for the wire. For the serious calcific lesions, sometimes there might be plaques that prevent the wiring of the side branch. Then after the plaque modification or clearing the calcification, adequate main lumen clearance can be created, and then side branch can be wired. In the challenging cases, U-shaped reverse wire technique or hairpin technique can be adopted. For the dual lumen or angled microcatheters, side branch can be wired. But this is the last stage. With dissection, the side branch may be lost. And about the twisting of the wires, this may be a challenge, and retrieving the wire and the engaging the system to the forward is an indirect indication of the twisting of the wire. How we can prevent it? So we can pull back the wire, and without much torque, we can reposition it. Which wire to pull back, especially for the tortuosus or dissection developing after predilatation, or if there is occlusion possibility, we can keep that wire and reposition the wire. Without much torque, we can move it, and sometimes during the wiring of the side branch, microcatheter or dual lumen catheter can be used, but in that case, as the end of the wire may be weighted higher, dissection occurrence possibility mustn't be ignored, and keeping too much to the distal and possible perforation may be ignored at the distal part. If you are suspicious about this, pullback is recommended. And first, a classical inflated balloon is recommended, and if it continues with oil, coil, or a cut balloon, or with a clot, intervention can be done, and a cover stent can also be done. In stage B, male vessel and side branch are prepared. The under expansion of the stent must be prevented, or stripping of the stent must be prevented. Therefore, the lesion must be prepared, especially in OCT if calcification is more than 180, or if the calcific plaque is thicker than 5 millimeters or longer than 5 millimeters. Rotational or orbital atherectomy, scoring or cutting balloon, or preparing the lesion with lithotripsy are recommended. When to prepare the side branch? Depending on the definition criteria, in complex real bifurcations, you can do it if the stenosis is more than 90%, if the lesion is longer than 10 millimeters, and if there is serious calcification, pre-dilatation can be done for the side branch. Stenting is the last stage, stage C. There are a few recommendations about the challenges to overcome. There are 5 steps for the provisional stent implantation. In step 1, like in the previous paper, 1-to-1 stent is selected for the distal main vessel diameter, and we place the stent from the proximal to the distal. And here, the shortest NC balloon must be dependent upon to cover the proximal main vessel, and POT will do it. And in order to bypass the harder part, the shortest stent is recommended. And as I have already said, the distal marker of the balloon must pass the POT carina, but instead the shoulder of this must be positioned before the carina. And in the bench test done, this gives the best results. I mean, the shoulder segment must be in front of the carina. And if our stent is longer, then a second pot is required. Here, if a satisfying result is obtained, the procedure may be completed. But if there is a serious sledging in the side branch, then in that case, the side branch must be wired. And for rewiring at the distal struts, you must do it. And third wire or a distal main lumen pullback must be done. And we must be careful about that the distal segment must be used. And OCT can be used for this, is a golden standard, or stent bus can be used for it. And then again, side wall or to the main distal lumen, rewiring can be done, 1-to-1 balloon kissing can be done, and then POTS may be done to complete the operation. If the result is not satisfying, if the angiography is bad and flow is restricted, stenting the side branch can be considered. To sum up, this is the stenting technique. POT is required, and these 2 stages are mandatory for all the stenting techniques. And then, if the result is good, you can complete, or else distal wire and kissing balloon and final POT can be done. And for the pitfalls, one of them is malposition of the proximal segment. And in this case, what are the challenges? If a second POT is not done before pulling back, malposition occurs, and a second wire can be used, and substrate wire can be used in intranominal, and this third wire can be done. Detecting it with angiography is difficult. Low profile balloons can be used, and then kissing balloon can be done. You can see the deformation here. With a second POT, the operation seems to be good.
You said that it is taken to your stent. So there is interluminal, and through this time you can continue your procedure. Of course, there's a suggestion that there's a recommendation that no one has the tactile burning of the friction of the wire, the engagement of the catheter is important. That is could alert you. Another, there's a pullback rewiring, as I pointed out, that in proximal segment there's interluminal. You have to rewire, but you do to, so while you're going to the main lumen, there is a process distant, and you can wire the main plane, and as you can see, there's a crash and you continue, when there's a new, you need to rewire the main use, you can use OCT catheter, or you can see that the balloon does not go there, and the distal rewire can be taken. We have to, our time is up, and when we say make proximal rewiring, there's a deformation, there is the balloon interluminal can be taken, and there's an alertus, and there's art osteal lesions we see. So we can see there is overexpansion, and for each 1 millimeter extension causes a 2.5 elongation. From left or right cranial poses, there is a symmetric stent repositioning, and this protrusion increases. And with rewiring, and the procedure can be more difficult. So you can go to the natural, sometimes the system can take you a while. You can go through struts misleadingly. Natural lumen catheter can be helpful in this regard. And the second wire can be used in this one. And if there is a suitable port, this procedure can be ended for this rewire can be made, and there is a 1.1 millisecond can be done after the report. And if there is a problem with the advancing of catheter or blunt substrate, could be taken for rewire, the dual lumen catheter can be used. Thank you very much. We can have one question. We have a very limited time. So the publication is at 22 May. In one of the publication, is the microphone on? In the non-complicated, and while we are going to write a report, I wrote that the rewiring is not necessary. It is set with or without, but the others are with the port. It says that with or without report, if there is a shorter segment when we do not have NC, so it says that with or without report. Thank you very much for your speech. We will continue with the second speech. Nazif is not here. Ömer Bey is going to make presentation. It is the 2020 EBC technique. Hi everyone. Nazif Bey cannot participate. There's a reason. I'll talk about it, and I'll make another presentation. I just learned this. He cannot participate. So I'll talk about another subject. What to do when the balloon won't cross into the side branch. The challenges in this. Taner made a very nice presentation, and he summarized some very important things. And this speech will be like an exemplary case. It's about what to do. Balloon won't cross into the side branch. We are in the side branch, but the balloon cannot cross. So what to do in these cases? Bifurcation lesions are seen very commonly, and bifurcation lesions are among the most frequent approach and challenging coronary lesions for percutaneous coronary intervention. Kissing balloon is an inevitable and mandatory in two-stent strategy. This is very important to us. Double kissing and mini crush is there. There is a clot technique of the mini crush. We are using this rather than mini crush. Generally, while we are going to side branch, if the side branch stent is a 2.5, 2.75, in the side branch crossing, after have this, you can use a low profile balloon. For that 120-1.5 balloons should be used. The pot is very important, and without pot, you shouldn't make rewire. Then I explain the reasons why. There could be a need of extra support wire in the side branch. We don't have the collider balloon in Turkey. Sometimes we make the rewire, but we cannot have the crossing. Maybe anchor could be better if it is a substrate. If we push it too much with the anchor, with the guideliner support of 1.0, stand could be used. And for that, if you cannot cross in the first time, you cannot continue with anchor. You can have rewiring in some of the cases. If you have a suspicion, of course, rewiring is very important. There is the use of microcatheter use. The W1 catheters could be used. Instant anchoring is something we do very commonly. The kissing balloon is very important. Having the anchor and continue with the others is very important. And there's a body balloon technique. You can use this technique as well. I'd like to show you such a slide. In bifurcation lesions, sometimes we use short wires, and it's very difficult to sync them. And so we have such a fabric that should be a thick fabric. With the use of this, we can just sync 3 wires. So this, in the beginning, there is the main branch wire, and in both parts of the sides of this fabric, we use the sides branch. And we see the main branch and side branch. We can make a section like this. Part is very important, and without part, so we can think this there is a 1 millimeter of area. We can think how the strut is there, and when there is a strut, 1 or 2 struts, that makes the procedure easier. I'd like to show you an example. There's a diagonal stent, and with a very short balloon, it is used. We have 6 mm balloons in our country. There's 8 millimeter and 6 millimeters balloons that we use. For the pot, sometimes you can find the short balloons. The crush technique is such a technique that we are using very commonly. But the problem is that in the provisional standing, the most go to distance, and mini crush you should go to the proximal or the midway, because after the crash there is an opening there. The wire enters here and it goes here, and the balloon will have push the osteotomy struts. Even if you are doing a kissing, you can say that of course you cannot stand this part. And the mini crush technique, one of the most important things, one of the most important problems is going substrate. In another case, you can send the banana. After putting it to side branch, there is the crush. This is our case. There is a knuckle. We shouldn't have crush C. We had a case, but the case was enough for us. While taking out the wire at the edge of the wire, of course, you should pay attention to the wire. You're trying to take the wire, because there's a problem. You cannot go through a balloon with it. The wire is left there. There's a second wire. Put it in the midway. The second wire is below the first wire. Another important event and advantage is that anchoring advantage. We are going to make a kissing. And before kissing, you can have a short balloon, make dilatation. There's a support of this, there's support of anchoring as well. You can continue with two kind of supports. After kissing, the kissing has been mated. It was going to be a provision. And you can assume it's dissected. It's a dissection limiting the flow. This causes pain. However, we can see from mid-throat the wire is sent. Balloon doesn't cross into side branch, as you can see. You can have the guideliner support. The anchor is a technique which is used very much, and with the anchor, you can. The internet of the professor is not very good, and sometimes we cannot hear what he's saying. The interpreter is not. After the kissing, that is the image that we have. We have the body balloon technique. We are not using this. That it's depicted though. As you can see, as the balloon is there, there's a counter wall. The pulling effect is there. The balloon is inflated. As is the anti-crossing power. We don't use this technique very much. Anchor solves many of the problems. Mother and child technique. This is Özgür-based techniques. Mother and child and mother technique. In many of the unsuccessful cases, this makes us to be successful. There's the OM bifurcation. We use guide extension for the stent. With the 6F guideliners, we use 2 wires and we make kissing. With the low profile balloons, you can make kissing. We use also 6F guideliners. We use micro catheter. And this is a very good, and we use the other catheters. You can use the side branch crossing. We started to use we wanted to wire that part, but we couldn't wire, so we used the ballooning, and then there is not wiring again. And we put the stent, but of course the patient has a pain, so we try to rewire this vein, and we tried, but we couldn't do it. So you can see after we are in the ostium with the ventral support, we can go to side branch. These are used for the same lumens for the same catheters. This is the image after kissing. The flow is back. Although it's not good. There's something like, this is the last slide. Side branch predilatation. Before rewiring, ballooning, before rewiring, this is something I give attached importance to. If we have if there's a rewire and kissing, if we are going to put a substrate, we shouldn't balloon this part. In this patient, for example, you see that there is a very important. We can have this is self-stent, so you can see this is the result. Of course, you want to rewire the case. It is not a very small vein. So we put it and we put a second wire. And of course, you have to have the second phase stent, as you can see. It is not very small diagonal. I'm very obsessive about this. If there's going to be a rewire, there could be some ruptures that you cannot see, but the wire can go there through the ruptures. This is the last case. It was a very difficult case. I will show you what we have still with the IVUS, and the mini crash technique was used. We put the stent in the second wire. Then we rewire with the help of balloon, with support of balloon. This is inflated balloon. It shows that there's some air, but then we use a wire, we use a deep wiring. It's an extreme support of this. We use anchoring. Although there's anchor balloon, although we made a deep wire, the balloon is not to go there. We use guide liner, but we couldn't use it. And we opened the LED CT of the patient. This is the diagonal part, and we couldn't take it back. Sometimes there can be patients, none of the procedures are working in these patients. So three things are very important: potting and repotting, and the balloon anchoring in the sand. I think that it's a practical method. And also while we are rewiring, we shouldn't do predilatation. Rewiring, if the balloon doesn't cross, so you should have a second wire, and you should balloon through this wire, and it also many problems. Thank you very much for your patience. Thank you very much. No news from the live case, right? Let's look at the panels, friends. Any questions? We have Amarbe, we have Tanarbe. Anyone who would like to ask a question? All the side branches. Should we wire all the side branches? Which side branches should be? I asked a question for discussion. Let's, according to me, so all the side branches above 2 millimeters should be wired, but this I'm curious about your experience. Even the septals I'm trying to wire. Taner Bey, in the provisional stenting, it is mandatory, and of course the thin part, and if it is about 50 millimeters long in MPPC and ischemia, they can dilate more than a huge area. So in the provisional stenting, this should be required. I was going in consensus is post side pot, and if of course a pot distance should be arranged very well, and that attention should be paid to this. Anyone, any questions, any comments? Sometimes you have to be quick about it, and the hydrophilic side branch should be selected. There were in the past, some hydrophilic wires were selected, and it should be hydrophilic. This is the jail wire. In some practices, we see that and until the end of pot, the side branch wire should not be pulled out. While you are making a pot, it should be 1 millimeter above a carina, and a repot you shouldn't go that part. It should be made above, from more proximal, right? About the jail wire, you can just pull it out if there's a larger segment, or if there's a very calcific vessel structure. You can select it, pull out before the pot. Sometimes the wire can be interrupted, but can be cut down. Sometimes pulling the tail requires expertise. If you have the pots, and if you're going to close the case, while pulling out the jail wire, we couldn't hear you. You said from guide catheter. While the guiding catheter should be taken ostium, and you can have the jail type, so that there's no engagement. And for that, as is the catheter, you have to have the wire, and we take out the jail wires so that we can have the anchor, and we can have the imaging, and we can finalize the case. What I do is that if there's a diagonal LAD bifurcation, if I'm going to take out the pull, we will take the fail and I take the CX. CX prevents the engagement into the we have to be careful, and then we can use this technique as well. And actually, it's so in a complex LAD, I have used a circulator. The reason for this is that the catheter engagement should be prevented, and I think that is a very good tip. RP has a question. While wiring before stent, wiring the side branch, I believe that in the bifurcation in the distal, the sizing can be used, and anchor could be used, and using that could make you crossing to side branch better. and easier. The distal ankle is set, and before stenting, this could be done as well. I think we still have time. Can we finish? We can finish. Thank you very much. And now we are going for the live case. Distinguished colleagues, hi everyone. We have exceeded our time a bit. In the last session, we will talk about chronic total occlusion. We were going to be Nihat Bey third. We have Vijay Kürşat again. First and foremost, I'd like to invite Mustafa Çelik Galip Arısoy, the panelists Çağlar Alp, Murat Gül, Erkan Demirci ve Ali Kırbaş, and Anıl Şahin to the floor. Nihat Bey, hi, can you hear me? We can hear you. Do you hear us? We can hear and see you. We are managing the session with the Siyah Hoca. We can listen to you, or first we can start with the speeches. So we have two options. We can either start with you or with us. We are waiting patiently. But I'll assist, Mustafa Bey is going to do it. I'll assist first. We will present the case and then we can discuss the plan. Let's have the case. 50 years of age, women face that there's a diabetes. That this patient come to us with 3 months of typical chest pain. There is no pathology. There's echo is 55 to 60. You made the angio. The LAD is 100, chronic total occlusion, and it seeks almost 70 to 80%. CA is 40%. This is an angio from another place. There's a fail, and the national angiogram hasn't been made there.
There is startiosis. Our segment is nearly 2 centimeters, and you can see that this is a blunt CTO, and there is a septal outgoing. This is the natural angio. Let me show you the right cranial. The same angling is seen. There may be an antromyocardial cause. The distal seems to be thin. And there was a failure recently, a failed operation. Actually, it must be waited for a few months, but the application is a little bit early. Maybe CTO classification be done here, the blunt 2 type, a tried operation. There is angling. We are not sure about the angle. It may be upward. What are your opinions about the lesion and the case? Of course, it was tried earlier. It seems to be blunt-ended. The length is longer than 20 millimeters. We cannot see the vessel clearly. For the scoring, it seems to be a difficult case. First, I would like to give the floor to the panelists. My name is Dr. Willy. It's a difficult case because the blunt ends previously tried from the panel. The lesion is long. There is no calcification. 4 out of 5, so it's very difficult. Antegrade, retrograde, direct, which technique would you prefer? Antegrade technique up to 80-85% will be required as the lesion is a blunt one. In the first operation, in the images, there was a microchannel. However, in the previous images, a subintimal area will be is closed. Therefore, we lost the channel. Most probably, the wire will go into the subintimal area, as in the previous surgery. IVUS guides may be used. What would your wire selection be? First, despite it was tried earlier, I would try a harsh wire with a proximal cap and then continue with a soft one. If the strategy failed, then I would use IVUS guiding and a solid wire, confidence 9-12 may be used, a second or third to the guide may be used. And when we puncture the proximal cap with it, the distal will be easier. Distal landing zone is not wide enough. I mean, when we see the wire vessel diameter, it's most probably not a wide one. It will be challenging in re-entry and escalation, what are your opinions about this? After puncturing the proximal cap, do you think is it correct to define somewhere as a proximal cap? It is actually an area opening itself. I think in a proximal cap, it will not be that difficult. Most probably, when we use the microcatheter, it will be automatically going on. Natural lumen catheter, would you think of it? Parallel wire can be taught. Actually, in wiring, natural lumen catheter may also be used. Guide 2-3 confluenza whole net may be of use for the first inlet, and then after microcatheter is changed, the escalation may be done. But our main operation here is not to widen the subintimal area, because as we proceed to the distal, we would need to turn it into retrograde. We need to be gentle, not causing too much opacity. Is there another opinion from the hall? Nihat, this will be our general approach. There are options. What do you think about the case? We didn't think of much as rigid wires. We do not know the curve, the course of the vessel. When we do not know it, pilot is a good option. Most of the time, it is not out of the vessel. Subintimal can be used, and here ultimate Proskaya and pilot 200 maybe think thought of. we would use the pilot because we may be in the lumen, or if we go subintimal, it will be a good marker for us. Then we will continue with the parallel wire. If we are in the lumen, we will continue, but if not, Gaia or ultimate prod will be used. Sia, I have a question. I couldn't hear the last 3 or 4 minutes. CTO seems to be a long one. Is it really like that, or is there any part filled? This slit seems to be so. Yes, it is filled. The CTO segment is around 2 centimeters. It seems to be felt difficult from the circumference, and the LAD distal is felt from the RCA. The obstruction is not to the end, right? Can we see the recent views? It is filled until the curve. It's not that long then, because it seems to be long. However, the possibility is less. Here we see the filling actually. We will start with the pilot, then we place the microcatheter and we will continue. Yes, we can continue the discussion while you do the action. Yes, Dr. Korhan, we're listening. Well done, Nihat Mustafa. About the previous operation, do you know anything? We only know the failure. The system was not standard. The angiography was not natural. Actually, if we know how much dissection was done, we would plan better. But we use the late CTO, GCTO score, but it is not a good determinant about the success of the operation. When we look at the progressive scoring, the case is not in the difficult case class. Proximal tip is seen. Yes, there is dissection. The lesion is long. And from the RCA to the collateral, there seems to be a subtle thing. I think antegrade will be successful. Which microcatheter do you use? Corsair and Pilot 200. Can you inform us about the angle? 1 to 2 millimeter, 30 or 40 degrees angle. I'm not giving some opaque. The slit may not be LAD. What do you think? From different angles, we need to verify it. The segment CTO is a long one. In the first section, there is a connection with the channel. LAD was verified with the first images. When there is a connection, we shared it with the colleagues in the panel. Penetration is forcing. We cannot penetrate right now, unlike our expectations. I would think that there would be an obstruction, but I think we couldn't get the area in the first operation. Penetration is a good wire. The weight is around 4 grams. Your guiding seems to be backward. You can increase the backup. What was the wire? pilot 200. Penetrating the pilot or hydrophilic wire seems to be difficult. We will continue with Guy. We didn't take a pilot course. We don't know the angling there, but we need to be more controlled. We need to keep it under control. What is the progress barrier for net? Okay. For the lesions you cannot penetrate, what are your options of wire? Which one do you prefer? If there is a penetration problem in Gaia 2 or 3 and hydrophilic wires do not work, my next option will be Concast 9 or 12. Apart from that, for the other wires, Hornet 14 Probia can be used, and in Concast, the rigidity of these are similar. Mustafa did the penetration. We would do at retrograde. The angle is different now. It may be diagonal, right? It seems to be side branch. Can you show us the antegrade penetration area? Yes, we will show it to you. Sometimes the Gaia also requires angling. Most of the time it is straight. Sometimes we give the angle to the Gaia. We are not sure about it, whether the guide is diagonal or out of the vessel. About the vessel course, we have some suspicions. Maybe a CT angio could help. Right. Let's see it from the front side. We will see the diagonal angle now. You can see that there is not a clear diagonal filling. We could place the wire there, but we don't know. There is no filling. Leave the wire there and send a second wire. Yes, we will try it. Now we have changed the angle. Now we are out of the course of the vessel. Take an image to see the penetration place. Instead of continuous drilling, do you prefer sliding? Changing the direction of the wire? Yes, very good. With the sliding, we are getting a retrograde image now. Depending on the wire movement, we will understand the place. Here, actually, with microcavity, we can move forward, and if everything is okay, we will be in the lumen. If it is not going to the distal in the subintimal area, then a second second way can be chosen. How do you feel about the guide wire? I do not use the torque, but we need to use it. Mustafa doesn't use torque. Mustafa's CTO is something different. So sometimes you need to give half torque, 1-to-1 torque. Sometimes you give 30 or 40 degrees torque. Doing it manually is difficult. Some city operators do not use torque. There is such an option. There are a few Japanese colleagues who do not use it, but I do not recommend it. Do you use campus? They use. Here, would you recommend a step with hydrophilic wire? After this curve, you can do it. Turn around the curve. Do the escalation and seek for the lemon. What's the micron? Far cross. Hydrophilic wire will ease the subintimal progression. Actually, when SC on derivative wire is used, then it doesn't go downward. We can try a repuncture or continue with a parallel wire. We will see it. It's about controlling the wire. Well, we think that this wire is not in the lumen, right? In the vessel. Understanding is it's possible previously. I think the lesion was holding it. We need a retrofilm. Here, what do we do is that the Gaia angle is not adequate, and we gave 10 to 12 angle to the Gaia. And it's directed us to the lumen. And the distal state was distorted. Try some branches, please. It's okay. Entering into 1 or 2 branches may be of use. It seems to be in the lumen. Sometimes when this is subintimal wire, the retrograde position is disturbed. What Korhan said is important. Sometimes in calcific lesions and in angled bounds, we see it, especially using complex torn or Gaia wires. After a certain stage, the lesion squeezes the wire. It becomes difficult to go to the distance. So a perimeter covered wire is easily taken to the distal, and moving with a microcatheter becomes easier. And you need to check it from a reverse position. We are in the lumen, the wire is good. While progressing, we need to say a few more things. Sometimes torque is of use. A few torque may help us. With a slight torque, we will go to the distal. You see, it is easily going on. For demonstration, a tip injection would be good in the distal. After this stage, after tip injection, it will be good. No doubts about this, right? We see the release. The blood is really good. We can measure the pressure. And the demonstrations are quite good. We are getting the pressure around 40 or 50 millimeters mercury, and it's very good indeed. Can you show us? Can you see the pressure? No, we cannot. What's the pressure? Around 60. Do active type injection. Do you use it routinely? No, I just do it for demonstration. I just ask for it for demonstration. We can do an IVUS for this and then make a decision. After type injection, continue for a little while, and Korhan will also present a case. And after you turn back, you can show it to us. Well done. We can continue with the discussion now. Friends, the wire selection was really good. You went on with Gaia. I think everything is really good. We have a restricted time, Nihat. We will continue. You can go on with the discussions. Tian will be delivering a presentation about integrated techniques in PCO. Distinguished chair, distinguished colleagues, integrate techniques in CTO. I will be talking about this. You know that in integrate techniques, integrate wire escalation is the prominent technique about manipulation. Then comes dissection and re-entry using a device. And in wire escalation, many devices, especially dual-element catheters, may be used to increase the success in integrate techniques. Thrombus accumulation and then replacement with fibrotech tissue all make the CTO more difficult. And when we look at the vessel from different angles, there are different heterogeneity. Somewhere the fibrotech tissue is higher, and in some segments calcification is higher. And in wire use, escalation and descalation possibilities differ, and which make us change the wire that we use. And in the evolution of CTO, the anatomy must be kept in mind: the occlusion length, calcification, angling, the vessel size, side branch presence, antegrade and retrograde collaterals, and which segments are filled with them are all important. But blunt stent, bifurcation lesion presence, the lesion and tortuous course are all predict the success of the operation. When the CTO is short segmented, generally we are more confident, and when the distal visualization is good, it is related to finding the right lumen. And in angiography, we sometimes do not differentiate it. In CT angio, lesion length and calcification existence are important in the success of the operation. And this is GCTO score. We already talked about it. And when we turn to retrograde with low JCTO scores, and with lower JCTO scores, most of the time with integrate techniques. We become more successful when to use integrated approach. If the stump is tapered, if the CTO segment is short, visualization of microchannels, and when there's less calcification, integrate technique is also used, but we must be prepared for both the integrate and retrograde techniques. Of course, we should use dedicated guide wires and microcatheters, and parallel wire technique is important, and IOS guidance is important, and these increase the success of the integrate technique. And this is the slide of EuroCTO Club in 2018. Generally, we start with the floppy wires, and then we complete the technique with Gaia. And generally, with a wire shaping, we continue. Sometimes a second bend is required to increase the success of the operation. If there is a tapered stump, on the tip load and polymer jacketed wires can be used. If there is a blunt cap, we need penetration wires, and after progressing in the vessel, the escalation may be done to move within the lumen. And if there is a high calcification, every escalation can be done with a medium tip load wire. And these wires are generally of Asahi, but we can also use Confiance and Hornet to increase the penetration capability. The presence of microchannels is important. Microchannels seem very good, and we will continue with the view samples. Dual injection is important. There is a short segment and microchannel is present, as you see. The cap is very important. A good backup is given with a good view, and to allow the wire manipulation, and with a gentle manner, you can catch the microchannel without causing any knuckles. And when we need support, we can make the microchannel closer to the lesion and confirm that we are in the correct limit injection. Another CTO segment, ÇİFT, a polymer covered wire is progressing, and then the wire is changed and successful completion. LAD CTO, here you can see a microchannel, and within that channel, a polymer covered wire is used. And with a flappy wire, the wire is replaced and the operation completed. You can see that actually when we evaluate the CTO segment, there are connections, and this is a wide connection. The wire is going comfortably. In RCA, we see a good injection, but when there's a connection, we see it. Polymer coated wire is seen, and polymer XPD is progressing smoothly. Sometimes there are side branches, and in that case, a tapered area is not seen. Most of the time, a blunt stump is seen. Therefore, wires with high penetration can be selected. For gentle manipulations within the lumen, you can see it in distal injection. If you confirm that we're in the right lumen, the microcatheter may move to the distal. ABCTO short segment, our wire is Gaia here. Look at the manipulation within the lumen if possible. Gently we stay within the lumen, and with a torquer, certain angles are kept, and true lumen is trying to be kept. Another case, a long segment CTA is seen, and in the distal segment there is a channel and a side branch. This is a filter wire. And with gentle manipulation, you catch the micro.
When it's a certain segment, the wire is not enough to penetrate, you need to have the microcatheter. As the wire support increasing, it crosses itself. And we look at we are in the true lumen, and of course, after that, we can have the stenting and we have a successful result. This is an latest CTO case. As you can see in this case, the barrier victim function is not very clear, but our wire, it's a Gaia wire, but regarding penetration, we are having a problem. When you have the second angle, there's a tendency to knuckle. You have to go with the microcatheter and you have to continue with it. To knuckle, there is a tendency, there's a calcification. It covers the area where it will have the function. And if you do that, there is a different dimension of the work. And of course, after the function is conducted, you can see the crossing of the wire. You can just follow it. With the microcatheter, we support the wire, the penetration capability increases. You see that there's a true lumen orientation. And the key area, there could be a problem. You have to look at from different angles with retrograde injection to see. We are not sure that we are in the very true lumen. As you can see, when you look at from different angles, we see that the wire is there. We just pull out above. We have you might have changed the wire. We use it. We are trying to be in the true lumen, but we are not in the true lumen. So we take it above. We pull it above, and we can see in the true lumen. We cross the wire from the different poses, so we confirm lumen microcatheter crosses the distal, and it's the second, and this is the final part. Sometimes calcification and tortuous it could be there, and these are the difficult passes. But I use pilot 200 with a polymer wire. As you can see, Gaia can be selected as well, and there is the part of the wire, and you can have the microcatheter there. We are within the architecture, but we are not in the lumen, but we can be in a suboptimal area, and with regards to the wire, we can have we can increase the fire, and we can continue to pilot fire with different small manipulations. We select the true lumen, and we see from this we are in the true lumen. And the more we can advance with the fire, the microcatheter can cross more, and it's, in terms of support, the guiding catheter is important. And you can see the final pose of the imaging of the procedure. In LAD situ, there's a blunt stunt, and there's a side branch crossing, and the area of penetration. This gives us a hard time. We have IVIS guided penetration is recommended here, but when you look at from different angles, the guide is like an accordion and shows that we are in the supraintical area, and in such a case, we use the parallel wire technique. You should you can have a better penetration capability wire. You say from the distal we are in the side branch, and after stent implantation, we have a very good imaging. Another case, LAD CTO case. There's bifurcation, or there are 4 vessels from septal and diagonals are from the same part, and penetration is difficult. And if we use a dual lumen catheter is preferred with Gaia the wire, we can see that. And there is in the mid segment there is a part, and we can see that there's a distal part, and there's the side branch is challenging for us when you proceed with the microcatheter. With the microcatheter, it's you can function the second through lumen. With you have the small and kind manipulations, and it penetrates this region. And you can see when we look at this injections, we're in the same, we're in the true lumen, and our catheter has the positive case. So when you cross downward from the lumen, there's a type injection. Without we can confirm that we are in the true lumen, and when we just important that we can have this, we can have the plug wire to the wire. This is the image after the procedure of the case. This osteosis CTO is a challenging lesion, and this makes it difficult. And with the catheter, with the use of dual-lumen microcatheter, we use. With the dual-lumen microcatheter, the penetration capability decreases, and through the wire that you are making the wire, you can increase the penetration force, and you can continue. And this is the final imaging of the case. Difficult cosmic case with the engagement. I'd like to highlight something. We didn't have an extra backup catheter. The reason why we didn't have extra backup catheter, we couldn't do the punction from the right place. We have the anchoring, and with the anchor catheter we approach, and our backup increased quite much. And with the manipulation, this is 14 instead. From the cosmic segment, we're trying to advance, and the anchor gives us a backup, and you can see wire continues and crosses and advances. We change the angle, so we check whether we are in the true lumen or not. And this is a real-time imaging. We have the angle, and as we continue, we can see that our wire is within the lumen. We can see that very clearly, and from then on, we can have the lesion, and we can say the result is quite satisfactory. Another total occlusion, LAD ostial segment, as you can see. The penetration capability, for that we have the extra catheter, we have a micro catheter to read the penetration area, and we can have the penetration. And after that, we have to confirm whether the wire is within the true lumen or not. So there's a diagonal side branch, and there's a penetrated wire. We see that it's advances to diagonal, and we confirm this with the injections, as you can see here. And at this very stage, dual catheter is increased, so we can see that function is very good here. But regarding penetration, we see a problem. We have the trap, and we orient microcatheter to LAD, and after the microcatheter to LAD, we have a better penetration capability, and we continue. And as you can see, as Nihat pointed out, as you can see in the right-hand side image, the final wire is pilot to 100, and with that, we go into the lumen, and we can see that there is the increase of this, and this is the case. This is the last case. So there is a tortuous vessels we have. This is the vessel. We don't know what it comes where, but we have the when we advance with micro catheter, we saw that there is a canal there. And in the right branch, we sent a wire with the left upper catheter. We have anchoring. We use a 200 pilot 200 wire we use, and there is a tendency of a knuckle, but you shouldn't do knuckle here. There's a lesion. There are 8, and this is a different interesting shape here. So here divided as a retrograde injection, there is a posterolateral branch we are in, and of course we do not prefer this. Of course, this wasn't a branch that we prefer at the system, but it's and when we advance and posterior descending, the posterior antisense is there, but we cannot have the microcatheter here with the anchor. The microcatheter is right to be advanced, and we were successful in this. You see pacifier accordion effect, but we couldn't see where we will stand. So from the side branches, we have to compromise. And this is the side branch that we want to save. We have the stent implantation. We have a large vessel with the retrograde injection. We see that it is a jailed in there, and clinically speaking, and the patient, we had received a very good result, and we received it. That's why, and the patient is asymptomatic. So as a result, so you need to select the easiest, and the most reasonable technique to start. Use appropriate guidelines for type of lesions by the help of microcatheters. Antegrade type remains a founder of a CTO PCI. With the, of course, with the manipulation, with the backup devices, and with the backup catheters, you need to have this. Of course, you need to have the manual skills for that. You cannot say that I'm very good, I'm done, then there's a failure starts for but you shouldn't be, you should continue learning tip load, tip angle, torque deflection are important words, and you have to learn them. And sliding, drilling, penetration, and knuckling, as Korhan pointed out, when you have this sliding, you can see how the wire is crossing very easily. You have to select this with anatomic characteristics, and it increases the procedure success and achievement. Thank you very much for your kind attention. Thank you very much. Any contribution from the panel or from the hall? I guess not. Should we connect to hall? Can you hear us? Or maybe we have limited time. Let us tell what we have done. As you can see, we made a digital injection. We had the segments, and there's we made the balloon dilatation. We received balloon 2.5. It's a lady. In the ostial part, there are branching. We increase the pressure, and then let's continue. This is the imaging, and we have the iris. And let me show us the iris. From the distal, as you can see, distal. And the distal, the vessel looks thin. It's not like a load, so there's a spasm to an extent. The plaque load is 30% or 40%. We can understand whether the vessel is there, and we can understand that this, if the vessel is thin, we can interpret it as a spasm. We have reference segments, so in the iris, so in 3D, let's go back a bit. Our diameter is 275, vessel diameter. So when there isn't iris, do you control this with this? Sometimes the spasm, we have to do that, but the optimal is the optimal PCR. Optimally, we have to make iris. sometimes we cannot solve this problem, and what we understand is that in the control angio, so we can say the vessel is enlarged, and as we have seen it, all of us have seen it all. The proximal LAD. Go back a bit. We have a problem. In the lesion part, there is a positive remodeling. This is a large area. This is where the septal is going. We have a reference point, but we have when you look at the proximal LAD, what do you say, Kürşat Hocam, Ziya Hocam? The area where is septal, there's IVC catheter. From this septal part, we have to put the stent here. What should we do angiographically? Are you asking about stent implantation? So we can put it in the septal as far as I see, maybe from a different pose, or we can say when the proximal part, and we can say this is what I believe. So do we have proximal in terms of can we have to assess the proximal segment? We have the region measurement. This is 3.6 LAD. You can see the proximal LAD. Can you see the IVUS? It's 4.6. I think that there is a spasm. We are not thinking of stent. Let's have the coagular angle. You can say it's better. It seems it is looking better here. From the same time, we implemented the place of the stent with 20 or 30. We have 22 or 30. We were discussing this. So this LAD period, I think that have a lesion. Ömer abi stressed that because of a different system, there is a the upper part is from ipsilateral. So from this perspective, there could be a narrowness. I think that there could be a narrowness from that part, and the proximal segment is a stent, so we can think a balloon into the distal, or there could be the dilatation can be taught, and of course I think that of course I have a concern about this part in the CTO cases. So you're saying better, you say the cases better. We have a 2.5 balloon, which in proximal and the distal, as you can see. Go back a bit. Go back. Another go back. Go back. Go back. What do you say, Professor Ali, in this regard? Ali says that it seems a bit serious. We're thinking of closing that part. A medical balloon can be that after proximal CTO, I use the balloon. We are working angiographically, but we have very good phases, so we can, this is an option. I don't know whether you have it in the laboratory, and we can think of it before, without putting the stent. There's a branching there. You're asking the part of the diagonal, right? Let's close this part. It seems like it is dissected. Are you thinking of covering this lady? So the standard 275, onyx stent will be used, so 34. This is the reference is at 2.4. The flexibility is very good. It is not the shorter than proximal regarding onyx, right? The latest data shows that there's an elongation, 2 millimeter of elongation. I don't know the exact data about it. I'm pulling a bit. What do you say? What is your stent size? 2 is G0, no, 275. I'm Sefa Nihat abi. The wire is a true, right? It seems that there are small dissections. We decide based on IVUS generally in the cases. It seems very well. The first proximal part is a bit there. We will have a pot in CTO. The opening is very good. I will show you the stent opening with IVUS. Let's have the pot and the above part with 3.5. Stent visibility is very good. We use the same stent in the other case. While arranging this, some of the stents, the visibility is very low. Of course, there needs to be clear stent. We give radiation to the patient that the stents being visible and being with a marker is important for placing the balloon in the right manner and gives us opportunities. So when you go above it, so there's a HD dissection, and the proximal segment that needs to be stent, and I think that this is very useful. There isn't a diagonal there, it seems a bit near there. The faucet, we go to true. There could be a problem with that. This is a long segment that needs to be diagonal. Can you see the septals? Kürşat Bey. Mustafa's first wire go down there to the side branch, right? I think that's true. The septals are visible, very good. We haven't seen diagonal there. IVUS will show us. We can check IVUS. Four, 6, 10. We will not be very aggressive. 3.5, 12. If we have an order size region, we can work there again. We should inflate it. Let's see IVUS if it is otherwise, so we can check this. There could be a subintimal part there. There could be. Let's have IVUS. First film. This is very important. There could be a rupture here after the balloon. It will make us lose time, and maybe we can take with the contrast to the post-dilatation. Have nitrated the blood pressure is okay. We want IVUS. We cannot hear the gentleman speaking very well, so about the disorder nerve, so we have concerns. There could be ischemia. So we can check this part with the iris. We can treat this part as well. Sometimes the iris of fire can touch on the fire. From 6F guidelines, the iris can go in such cases. Show one channel, it will be wired. I'm changing the angle of catheter. So when you look at this, it is the system, and we just can we see iris in the larger screen? There's 80, no, there's not 80 or 30% plaque structure. There's negative remodeling here. It is not that small, and it is undersized and underfilling for a long time. This is a stented distal. We see that the angle is there. There's no H6. So I go to starting part with H dissection, very small, slowly, millimetrically. And it, of course, there's if this is more than 60 degrees, it requires the stent indications. What is the diameter angle? What's the diameter of stent? 275. Above 3.5. This is the area, and it looks very good. We can delete with a tree. Can you check this, whether there's a vessel there? Let me show you the proximal. Seems very good. What do you say? I'm taking two proximal. This is the problem, and from the very proximal, you can have the ostial part. The stent is more undersized. There's an announcement, and we have to open this part a bit more. You can code this down. If there's an increase in the lumen size, that makes us think of a branch. I'm pulling it back. Let's focus on the branch. I can see the branch there. We will plot this area once again. We will finalize the case. I guess that there's a case of Safa. But let's continue with Korhan's case. We will continue with Korhan case. We will have the last imaging. Korhan, can you present your case?
Can you see my screen? A right coronary CTO case, antegrade was done. There is tandem lesion. There are two CTO fields. Within CTO segment, there is bifurcation. And this, one of the two lesions is in-stent lesion. And 51 years old male. At the right coronary side, there is a stenting 4 years ago, and anginal attacks are defined in CCS 2 and 3, and metoprolol 100 milligrams, aspirin, thiazidine are given. Let me show you the lesion. In the left oblique projection, you can see that at the right coronary artery, in the first CTO segment, there's a microchannel seen, and at the distal part towards PGA, there's an in-stent CTO. Now, for this patient, for the right coronary artery, 7 French coronary artery catheter was used. This is not a strong catheter for support, but here you can see that anchoring is easier at the proximal side, and a second branch exists here. If we have any support problems, we use the anchor here. And at first, we progressed our microcatheter before placing the anchor, and then we will take it. The first wire was filter XD wire. It's a tapered wire with polymer ejected. Microchannels are used very well. So while using it, if you sense that it goes to the subintimal, we need to avoid a subintimal tracking. Sometimes even experienced surgeons suppose that they are in the lumen, but in the distal side, ballooning is done. This is not also 100% secure, but microchannels are used very well in many patients, as also presented by Kürşat in CTO patients. This is generally the first preferred wire. In tandem lesions, the microchannel is seen clearly and the filter is passed very easily. And then a fine cross microcatheter is seen here. And after this point, we did our anchoring. Without an anchor, it is not possible to proceed forward. For this case, we actually needed to do the anchor earlier. The stent is here. Now our filter XD wire is at the beginning part of the distal stent. And in the instant lesions, while progressing, we need to control the wire from orthogonal positions. And it's a wire seen very good in a position, and in another position, actually, it is seen that it's not progressing there. Therefore, from different angles, we need to see it. Here, in the proximal stent part, filter XD wire cannot penetrate, and a non-tapered and non-hydrophilic wire is used. This is a strong wire. It is going where we push, as it is hydrophobic. Apart from your direction in the subintimal area, it doesn't proceed much. Therefore, for instant lesions, I prefer this one. And this wire in the left oblique projection is very good towards the instant area. It proceeds. However, in the orthogonal position at the right oblique, the stent is actually going subsidereal, and in the instant stomosis, when the stent is not expanded well, there is such a possibility. The stent is not in the correct position now. And then when we reposition our wire, it is directed to a more correct location on the right oblique projection and right oblique projection. The wire is in stent. When we approach to the distal of the stent, it becomes difficult to pass the cap, distal cap. There are many images actually. We did right and left oblique here, and not only in one position, we proceeded almost in all positions. While passing the stent, we confirmed the position of the wire. Here towards the distal cap, we are closer to the mid and distal. This is our PDA. We want to proceed to this part. And here, we couldn't proceed with Miracle 12. After working 10 or 15 minutes, we preferred more rigid fire, and which is Confianza. And these are also determinator wires. Therefore, these are the wires that we terminate the procedure. And we must be very careful while pushing them. And you can see the retrograde filling here, and we made the Confianza reach the distal lumen. And we are in the distal lumen. Whether we are in the correct lumen or not, it can move in the subintima. For a few more times, we need to check our projections. And after passing the microcatheter, we did a tip injection. It's not routine, as also shown by Nihat. The pressure trace that you take from the microcatheter may help to verify your location. Or if you see a good bleeding, you can also verify it. Sometimes there are bleedings in the subintimal, but the lumen bleedings show it better. In some cases, again, if we still doubt, without much pressure, with tiny injections, you can do the injections and verify your location. And we changed our distal wire with another one, with a floppy one. And after pre-dilatations, we ensured an anti-glide flow. And here, actually, we have a CTO, side branch CTO, and bifurcation. While proceeding here, as we do a balloon, the right coronary artery has dissections along, and we can go subintimally, and to proceed to the side branch, we need a good angle. For this, one of the most appropriate approaches is double lumen microcatheter. And for this case, we use double lumen microcatheter, and the PL branch want to be wired here. You can see the Sasuke microcatheter with double lumens, and here, while proceeding in one lumen from the second hole, we use the other wire for the side branch. Again, after a few trials, the PL wire will be here, and then we will do pre-dilatation for both branches, and then with the older stent, which is towards PDA, we will do a QLAT here. What was the latest wire? This is a case I did 1 year ago. I couldn't see it in my notes, but I guess I used Miracle. Because I do not remember, it was a case 1 year ago, but when I look at the wire, I think I used Miracle. But here, a polymer jacketed wire could be used. In the midline and proximal line, stenting is done, post-dilatations were done, and then the kissing at the distal and the pot was done here. And the final angio is like this. I can answer your questions if you have any. Well done, Korhan. Any questions from the panel or from the hall? No questions or no contributions. Thank you very much. Ömer, would you like to add something? Well done, Korhan. Mustafa, can you hear us? In IVUS, when you see the OCL is not opened well, the balloon used for pot was reused. As there is nitrate, there is hypotension and diffuse spasm. The general condition is good. We will now complete the surgery. It seems to be good. Well done. Hope that the distal